who we have on the line. We have various OHTs are actually joining us. We have primary care, home and community care, community paramedics and emergency services, and some representatives from our digital health working group, as well as our OHT team. And looking for a few more from hospital are also expected to join.
Hi, everyone. My name is Dean Henderson. At Careteam, I lead customer success. So I support all of our projects from implementation, onboarding, and ongoing success. By background, I'm an occupational therapist, and I'm really excited to be here to meet everyone. Simone?
Hello, good morning, everyone. Simone Patry. I'm the Senior Program Lead for SHIIP. SHIIP's been in the Southeast region for 10 years now, and certainly we are looking to expand across the Ontario Health East region. And we've started doing some new data contributions in the Champlain region and working in some areas in Central East as well. Good morning, and thank you again in advance for everyone's time. And back over to Jeremy.
Thanks, Simone. It's a little bit better now. Jeremy Smith, co-founder and Chief Commercial Officer of Careteam. I look at our product development as well as our implementations and Dean's area of customer success. Can we do a quick roundtable of introductions of the rest of the group on the call?
Sure. If we make it very quick, I think we can do that. Christy, you want to go first?
Sure. My name's Christy. I'm at the Petawawa Centennial Family Health Center. I'm admin here, and I also play a role in the Health Links.
Great. Oh dear. Judy?
I'm Judy Hill, the Executive Director of the Petawawa Centennial Family Health Center and admin lead of IVC, Integrated Virtual Care. Hello.
Emily?
Hi there. I'm Emily Van de Klipp. I'm the Executive Director of the Arnprior District Family Health Team.
Stephanie?
Hi there, I'm Stephanie. I'm the commander of the Community Paramedic Program here in Renfrew County.
Lisa Jackson?
Hi, good morning, everyone. I'm Lisa, and I'm with the OVOHT.
Mathieu?
Mathieu Renier, Deputy Chief for the County of Renfrew Public Services.
Aaron?
Hi, I'm Erin McCabe with the Regional Palliative Consultation Team working in the Renfrew County area.
Lisa? Bradley?
Hi, I'm Lisa Bradley. I am a clinical director at the Pembroke Regional Hospital.
Ernest?
Ernest Ling, Digital Health Lead for the Ottawa Health Team.
Brian?
Brian Snarch with the OHT. I work on performance and analysis.
Brad?
Brad Boringer, Community Paramedic, County Renfrew.
Shauna?
Hi, Shauna DeYoung, Care Coordinator with Ontario Health at Home.
Natalie?
Hi, everyone. Nathalie Gilbert. I'm a Director of Patient Services with Ontario Health at Home.
Sarah?
Hi, Sarah Utrunk. I'm also a Director of Patient Services with Ontario Health at Home.
Monica?
Good morning, I'm Monica Armstrong. I'm the Director of the Ottawa Health Team at Keep Santé Ottawa.
Sonia?
Hey, I'm Sonia Silver. I'm a Clinical Manager at the Pembroke Regional Hospital.
And Jonathan?
Hi, Jonathan Fitzgerald. I'm a family doctor. I'm the Clinical Digital Lead for the OHT and Medical Lead for VTech and the Integrated Virtual Care Program.
I think that's everyone. Did we miss anyone? There you go.
Wonderful. Thank you, Jema. I'll jump in and say a couple of words of introduction and then give an overview of Careteam, and then Simone will speak to SHIIP, and then we'll do a wrap up at the end and have a discussion. And my apologies if I'm squinting. The sun is facing straight into my eyes at my desk this morning. I'm out on the West Coast, so it's still early in the morning. So an overview of what brought us together in the products. We recognize that you have two early priorities amongst the OHT around your regional integrated care model leading from health links and palliative care, and both SHIIP and Careteam have done work in both areas. SHIIP and Careteam bring to the collaboration a number of unique strengths, but also some shared areas that we can leverage and integrate together. And we'll speak to more of those as we go through. On the SHIIP side, SHIIP has a lot of functionality around being able to aggregate data from across the health system and presenting metrics and notifications around how a person is doing and if they're in need of complex care and helping to identify those patients. And Simone will speak more to those. Careteam has care plans which are actionable. You can, the items in there can be monitoring, referrals that are needed, follow-ups, etc. It has the patient family engagement side, the ability for the patients to define who's part of their team. That's unique on Careteam. And the parts that we have in common are functionality related to shared care plan, communication, messaging, and population health functionality. And so we'll speak to how we can bring those together to address the priorities. A lot of our background is in the space of electronic medical records, which is critical and an important part of the mix, but we found that it is just that. They are the medical record primarily of care that happened, and they are still relatively siloed, even though we have hospital systems aggregating their electronic medical records and physician offices to a degree. Still, you have the different components across the continuum of care and the important aspects of social care and the person and their family supports that all need to be able to function as a team. So that was what led us to the creation of Careteam. And to ground it in the Ontario context, you're probably all familiar with the Health Quality Ontario report around transitions between hospital and home. And these are very much the space that we focus on. The issues around lack of patient and family and caregiver involvement in the transition planning, the need for collaboration across the team to support transitions, timely support to engage home and community care in the activity, information for the patient, family, and caregiver so that they're ready for the transition and the family can effectively support them. And that as they move through the system and there's follow-ups, so that those things are coordinated, the person's not falling through the gaps and they're not having to repeat their information as much. So those are some of the key areas that we sought to address. These are a few examples of use cases currently that are particularly relevant to this in how Careteam is deployed. One is cross-continuum integration, areas such as our work around palliative care, where you have a large number of different organizations who are collaborating in the care of an individual in the community and need the ability to support them more effectively. We've also done work in dementia care in the same light, where there's a dementia network and a large number of organizations supporting people with dementia and frail older adults, particularly during COVID. We're also doing work in integrated clinical pathways where there's a well-known, well-proven care pathway, and we need to close the gap and make sure more people are able to follow the best practice pathway and have it personalized to them. Measurement-based care, where there's specific clinical programs, particularly in the ambulatory space, that are providing step care support to people to avoid hospitalization. And more recently, we're doing a lot of work around discharge coordination. We're working with the International Federation for Integrated Care and CIHR-funded Digital Bridges project out of Sinai Health. The principal investigator is Dr. Carolyn Steele-Gray, as well as Dr. Terence Tang and Walter Watches, who you may know, who are really looking at optimal ways to support the clinical team in preparing for discharge, and then the patient and family in primary care and community care after a discharge to make sure a person is appropriately supported as they move through the system and don't have to be readmitted. Also a lot of work around the at-home initiatives for the 8 16-week transition programs for contracted home and community care and the 7 leading projects. And then patient navigation is one of the priorities for the 12 accelerated OHTs. So that's where we work with our partner CareDove to either support a simple referral through CareDove or where they need to be supported by a care navigator. They come through Careteam, and the care navigator uses Careteam as essentially the patient relationship management platform to link out to all of the local organizations. So that's a smattering of the different ways the platform's used. These are the 4 core components. The first is the care pathways. As I say, we know that there are well-known, well-proven care pathways, and the issue is making sure that more people are able to benefit from following that best practice pathway. So we have a library of care pathways in the platform that can be applied to the individual. They can be tailored to the local geography and services that are available there, and then they can be personalized to the individual and as they move through their own personal journey, because not everybody's experience is the same. That care pathway is then used to drive the next two things, which are patient and family engagement. There's educational content in the care pathway, tasks for the family to look after, the ability to do remote patient monitoring on how they're doing. Then on the healthcare and social support side, the ability to support care collaboration and coordination across organizations. So it's the shared care plan and secure messaging across teams. And then lastly is the population health management. So the ability to do the traditional aspect of bringing up your entire patient panel and slicing and dicing it to identify people who may need more support. But then the unique thing is because their care plan is there, you can now function at a group level and apply what we call group actions to an entire patient panel, such as if you've got a new program that you want to make them aware of, or a change in services are available, you can now do that at scale rather than having to rely on human capacity to start making phone calls. So those are the four key components. We deliver this through a very naturally intuitive user interface. It doesn't require training. The training that we do at the outset is more around adopting the care pathways and best practices, but the platform is just like using Facebook or any modern platform. It doesn't require training. And we were actually just recognized by Fast Company, the big magazine out of the States, for the user interface design. I mentioned at the outset the fact that the action plans are actionable. The key part of that is also the integrations. So we integrate out to a number of the platforms that are in use in the province, so that if, for example, there is a task in the care plan to refer out to community service, you don't have to figure out how to do that. It's just click on that task and it'll take you directly into the relevant service in CareDove, and you can just make the service request or referral. That can be the healthcare provider doing it, or it can be the patient or their caregiver doing it on their behalf. We use Ocean forms for our online assessments. We're now integrating in with Petal out of Quebec to be able to do online appointment booking into physician offices. We have an integration with AlayaCare so that you can pull the tasks and scheduled appointments out of AlayaCare, and Smile CDR for access to medical record data. And we're just about to start the integration process this month with the Ontario MD Health Report Manager, because one of the things we've learned is that there's varying levels of engagement in the care plan. If someone's in a care coordinator, case manager kind of role, they're probably going to be using it on a daily basis or an hourly basis. But when you're talking about physicians in primary care, some may be that engaged, but a lot simply need to be notified that there's been a change in the care plan. So we're going to push updates out to the physician's EMR securely, and it lands there in an appropriate way. I mentioned the care pathways. One of the unique things about the platform is that it's highly configurable. So you may have many different care pathways in use in your area. And then we couple with those what we call a modular action plan or dashboard that can be configured to present the relevant information. And I recognize it's very small. It's not meant to go into the detail. I'll go into the palliative one in a moment. But I just want to highlight that this is all using the same functionality, but just configured for different use cases, for what information is relevant for that use case. So on the left, it's palliative care and the information that's important to share across the different organizations and individuals involved in a person's care in the community. The one in the middle is a type 1 diabetes pediatric use case, where the focus is much more around data from the continuous glucose monitor devices and enabling the clinical team to collaborate with the parents around adjustments to the dosage. So you see much more around graphs and data. The third use case on the right is hospital discharge in the Digital Bridges program. And that's around helping the acute care team collaborate across the medical team, functional team, and social and spiritual team, so that they're all on the same page of what's needed to help that person be ready for a timely discharge, and then engaging the patient, family, and primary care. So again, 3 very different use cases, all using the same functionality. I know that one of your priorities is palliative care, and that was a part of our collaboration with Mississauga Ontario Health Team and their leading project. We did a lot of co-design work with them, and you see in the bottom left all the details of all of the priorities that came out. But the ones that came out in the top right quadrant of most important in high readiness were these things that you see here. The ability to communicate status changes amongst the team, the ability for the clinical team to communicate effectively across organizations. And we heard that both from the clinical team, but also from the caregivers, who said that they were constantly having to communicate things to different organizations because they hadn't been able to communicate amongst themselves. The fundamental was team identification, knowing who's involved in the person's team and what their role is and who to contact when. Scheduling conflicts, and this is where our integration with Alaya Care comes in, because you can have, when you're dealing with palliative care in the community, there are so many different people coming into the home, and the caregiver simply wants to spend time with their loved one, and they're dealing with all the constant interruptions and changes of schedules and so on. So for everyone to be able to have a shared schedule is really important. And then being able to support through the transitions with a shared care plan. The referral friction is the time and lack of clarity around referrals out to services. And that's where the integrations to be able to do referrals out through CareDove and Chris and so on come in, that everyone on the team has transparent access to see what's going on. Those are the four things across the horizontal at the top. And then we also looked at each individual member of the team and identified what's important to improve their part of the process. And that's where we came to this one, which I showed on an earlier slide, but I've just zoomed in a little bit here to say for palliative care, what they identified at the end of the day for status changes in team and so on is the importance to see the team, which is here at the top left, being able to see each team member, what their role is and communicate with them, understanding what the person's goals of care are, and then the items that they identified that are important for both status updates and collaboration were understanding what the person's palliative performance scale is over time, regardless of which organization an individual clinician has entered it. And being able to know who entered it as context across the team. Secondly was the ESAS, the Edmonton Symptoms Assessment Score, your symptoms matter assessment, which is done by the caregiver, and being able to see how that is trending and as a part of understanding what the status changes are, and then being able to put in comments. So if the person's breathing is trending negatively, they can put in a comment and make sure that the rest of the team is aware. They can also put in status updates, so the rest of the clinical and social support team is aware of critical things before they go and do a home visit. On the left side, you see that it was also very important to them that there's certain things that must be done as part of the process. And so there's a simple checklist of things that's shared across the team so that they're aware. I mentioned earlier the fact that there's so many different people coming into the home. So we provided an integrated view of the calendar. So we can pull data from the EMR, from Alaya Care and home community care and so on, to see an overall view of all the different scheduled visits and who's coming to the home. And then lastly, the referrals and services, because there are so many different services involved, that some of which are done through home community care, some of which are done through CareDove for community support services, and some of which are completely separate. So being able to see the complete picture of what services have been requested for the person, and the status of them is leaf.
Jeremy, you're just
the clinical team, but also the deep dive on the palliative to wrap things, try to stay away from the traditional.
Jeremy, it's Jema. You are really breaking up, and it's very hard to understand.
I'm going to take over here. Give me a second. Thanks for your patience, everyone. Just going to the slide. And sure.
Thanks, Dean.
Yeah, so where Jeremy started to cut out with me was just at the end here, is just highlighting the referrals and services. So across the board, whether referrals made from one organization, being able to track and trend them across the team so that there's not a duplication of services or duplication of work being to make a referral to a specific service. So just wanted to provide a little bit more of a deeper dive into this particular use case and this dashboard that is customized for a palliative use case. And
sorry, Dean,
could I just ask you a quick question on the dashboard? Are you pulling that from, like, where does that information come from? Is it pulled directly from the EMR? Like, how would you know who's done referrals?
So if there was a particular referral made through an integration like with CareDove, then it would be made within Careteam through CareDove. However, it could be other referrals made through our integrations with Ocean.
Okay.
Or work done with Chris.
Okay, so any digital referrals that could be sort of fed into the system, it would capture it there, but anything that perhaps was done manually, it might not be there.
Yeah, you can add referrals that you've done manually, but that does take additional work. Yeah.
Thank you.
Thanks for flagging that. I just couldn't see anyone. If you have your hand up, just please speak up. All right, and really just to bring it home, Jeremy provided a great high-level overview of Careteam, but really highlighting the modern user interface where across all of our projects and use cases, the onboarding for the clinical team is very efficient, really an hour of time from the clients, patients and their family members and whoever they invite to their support team. There is no training, just the design has been very intuitive. So if you can use a social media tool like Facebook or LinkedIn or whatnot, there's no trouble there. Careteam really strives at making the care plans actionable. So think about from your clinical aspect, that everything that you've put in a plan for that client and making it actually actionable, whether it's another healthcare provider on the team or the patient or their many support team members that are supporting that patient. And those actions could be for caregivers that aren't within the region. So maybe there's a distant caregiver from Toronto or Vancouver or whatnot. Everyone's on the same page and can collaborate together. We've highlighted many unique partnerships from use cases with Trillium Health Partners, Mississauga OHT, Digital Bridges, and now with Can Health through the at-home initiatives, partnered with Briere, South Lake, and Humber River. We're hoping to continue that unique partnership, and as the theme of this presentation and this meeting is collaboration with a unique integration with SHIIP and Careteam. Careteam truly is person-centered, so everyone knows who's on the team. The client, the patient is part of that team. They can invite other caregivers or family members or neighbors to be part of that team, so everyone's on the same page. It's really putting the patient front and center, and that ties into the privacy by patient. So it is their choice, the patient or their substitute decision maker, who can be a member of that team from the patient support team type of thing. And then again, bringing that integration. So we are we do care plans really well, but there are many other amazing digital tools out there, and It's about bringing them all together, connecting across the ecosystem so that everyone can collaborate together to have better outcomes. Jeremy, I'm just going to pause there to see if you wanted to add anything before we transition over to SHIIP.
Nothing. That's great. Thank you, Dean. Let's hand it over to Simone.
Hello, everyone. I'm going to present the SHIIP portion of the presentation. So SHIIP is a different system than Careteam, obviously. We do have some similarities between SHIIP and Careteam, and that will be highlighted throughout the presentation deck as well. SHIIP was designed to be a valuable and complementary tool to healthcare professionals from every sector. The direction of SHIIP is supported by our services provider, Queensway Carleton Hospital, as well as the SHIIP Steering Committee, which is comprised of sectoral representatives. So we have folks that are on the steering committee from hospital, from primary care, community paramedicine. So lots of input and feedback and advice comes from the committee in terms of the direction of the program overall. We're here to listen to the providers on their needs in terms of the system capabilities. We also have a variety of functions and features available within the SHIIP application. I think a distinguishing element difference between Careteam and SHIIP is that we don't have that patient caregiver access component. So we are mostly a provider-based application. And with that, we do have real-time integrations with key sectors such as home care, hospital sites, addictions and mental health, as well as community support services. We have been primarily based in the Southeast region, and we are looking to expand in the Champlain and Central East regions as well. We do have a data integration with Queensway Carleton Hospital, and we're looking to engage with other organizations to activate data feeds. It's the real-time view of the patient encounters that can provide clinical folks information on the encounters patients may or may not have with sectors, and that can always be a good starting point for those that are looking at activating additional care plan processes. Knowing the level of engagement with a patient within the sector can help facilitate some of those conversations and planning activities. We originally entered the system to support the HealthLink initiatives back in 2014. So we host a coordinated care plan that was provided by Health Equality Ontario. Since then, we have activated other care plan tools. We have a palliative care plan that we're piloting with a hospital site here in the Southeast. We just activated a mental health care plan as an example. So we have what is called the dynamic care plan platform. Essentially, that allows and enables our team to take a modular approach to how we build care plans suited for organizations or one organization, so we can customize those care planning tools as needed. Identifying patients with certain risk scores. We've got calculations occurring in the background. We support the complex identifier. We also do calculations such as the LACE and the HARP based on the data feeds that we receive from our hospital partners. And in some cases, we can also calculate the M-Homer scale as an example to complement information for the palliative care population. And we also have mechanisms within our environment for alerting and sharing data amongst the providers. So notifications based on encounters with the hospital sites, or notifications can be configured based on care plan updates that are occurring within the environment. We do have initiatives to align to OHT needs. We have been in the system primarily to support health service providers, but with OHTs now in the system, we're also looking to support OHT-based projects as well. We have a project with we've linked with the Kawartha Lakes Halliburton OHT, and we're embarking upon several projects with them to support some of their planned activities in their region. And on to the next slide. Data contributions coming into the SHIIP program. There's a variety of things that can be achieved with the receipt of those data contributions. So first and foremost, it's that understanding of the encounter data across multiple sectors. We have a patient journey chart that will depict that very, very nicely. Any SHIIP user can activate a coordinated care plan. Any other dynamic care plan tools can be customized to meet organization needs. So if there was just a need to have a care plan with one organization from a security standpoint, we can customize even permission levels with those with the care plan pieces. And all of that information is available as well to the users to view as designed by the organization. You can view with the patient journey, you can view the continuity of services a patient is receiving. So we don't necessarily have any referral components, but what we see is the end result of the referrals for the data contributions that we are receiving. And for some of the data contributions, you can activate encounter notifications on key patient encounters and care plan messaging. And we also have notifications on our secure messaging component, which is attached to our care plan environment. Population health management has been a focus for our team. We recognize the RISE model that has been presented in the system at various different tables. And we do appreciate that population health management is evolving, for organizations and groups as a whole. I did like the RISE model because it had the 5 steps of the process of how population health management can be achieved. And I've just marked some of the key steps where SHIIP can support some of these components. So in terms of patient identification and with the receipt of all of the data contributions, we can use some of that information to identify patients. We can create subgroupings or cohorts in the SHIIP system. So certain groups of patients can be monitored. Of course, notifications can also be enabled on the subgrouping of those patients. We've got mechanisms to identify and query for different characteristics of patients. So those patients that might have a specific coded disease, or those who have engaged with the healthcare sector for in a certain period of time. So we have over 25 filters available within our environment that patient information can be queried. When it comes to co-designing patient-centered care modules implementation reach, we do suggest our care plan module in conjunction with our program management functionality can be used to support projects or initiatives. One great example that we supported in the Hastings Prince Edward OHT region was their unattached program. They would roster patients to this program management, activate notifications for those that are going into the acute care sector, and then provide care to those unattached patients. And for monitoring and evaluation, we have some embedded dashboards within our application, but we more recently released a new business intelligence tool. So that can provide SHIIP users sight to other system-based metrics. So we can do calculations like 7-day readmission rates, 30-day readmission rates are quite often popular system metrics. So those are available within our new reporting platform. And the next slide, please. Stemming off of population health management, so how we can monitor and manage patients, we do that through creating patient population groups within the SHIIP application. So as we are receiving data, we can allocate active patients to organizations. Organizations can then create subpopulation groups within the SHIIP environment, and these can all be managed by those who are within the system. Notifications can also be enabled, and and there are mechanisms to managing these patient lists within the environment. Really, the identification of patients to organizations, that's how we hone in on the information that's very specific to that organization. We, at the time of data integration, we have a conversation with the data contributor, and then as other organizations are onboarded, we make and build those links. So in this realm of primary care, as an example, the patient population list is built automatically, but there are also mechanisms available to users to manage those patient lists as well. This is just a couple screenshots on our alerting or notification system, recognizing that there is notification fatigue happening in the system. So as much as notifications can be configured and enabled, we've also expanded our functionality so that those notifications can be scheduled. We have a notification center available, and more recently, we've included our secure messaging notifications within our environment. We don't send any PHI in our notifications. It's more like an identifier that where a user can hyperlink back into the system to see the relevant details pertaining to the notification. And the next slide, please. Thank you. Very similar to Careteam, we also have a care plan platform. We transitioned our environment to a new dynamic care plan platform, and really that just gives us the capability to design care plans suited to organizations. All care planning activity is also part of the patient journey chart. So any updates that occur or any key elements that the organization chooses to present on that journey can also be presented on that journey chart. We can also, any of the information can be shared at any time. And we also have printing and version control mechanisms. So you can see who is updating what and when within the care plan itself. And this is just a quick snapshot of our population health management, program management functionality. Certain badging systems can be enabled, maintaining permissions on who can participate with the programs within the SHIIP environment is there. And patients can be added and removed to this functionality. And we do view this functionality to support things like if there was a specific program or initiative, tracking and monitoring those patient groups. And then this functionality also allows more than one organization to collaborate on the care of patients. So essentially, putting patients in common together for those that are providing care to those patient populations. And this is just a quick snapshot of our BI environment. So we have this just a sample of some reporting capabilities that we do have, providing charts and graphs, a variety of different charts and graphs that are available. We can also customize metrics based on organizational needs. All of our reporting is also based on the patient populations that are created within the SHIIP application. So it's not reporting on everybody and everyone that every patient that is presented to the SHIIP application. It's honed in on the patients that are associated to the organization. And that again is based on the integration conversations that we have with our data contributors. So there are a variety of advantages in this SHIIP application. There's the identification and monitoring. We also have the care planning tools that are available. Real-time notifications can be very critical for those that need to monitor patients more closely, and then also some of our reporting pieces that can help support the post-monitoring of programs or patients after programs are delivered. I did put just a quick slide on our onboarding steps. We generally have for onboarding organizations or data contributions, organizations can become a data contributor or a SHIIP user, or they can also participate the program doing both streams. Very similar in terms of enrollment, with the exception with the data contribution onboarding. It's more of a technical conversation. We recently aligned to the Connecting Ontario 2.6.1 specifications. We do call it Connecting Ontario Plus because there are some elements that the SHIIP program does require that's not available in the Connecting Ontario data feed at this particular time. We're also aligned to the the Ontario Health at Home specifications for that goes into the Connecting Ontario system. Although we are receiving similar data in comparison to Connecting Ontario, how we are presenting the information to users is just a little bit different. So there are some distinguishing differences between SHIIP and the Connecting Ontario system. We never visioned to replace the system. That system, as it stands, it's a great clinical-based system as well, where SHIIP can provide other mechanisms to manage population groups as well as support care planning activities. And that's the end of SHIIP.
Awesome. Simone, you and I can take it home here. I think
sure.
We're having some slower internet connections. So really, as we come to an end here of our of the presentation here, we wanted to highlight two very unique digital tools with an opportunity to come together to support the Ottawa Valley OHT priority needs. And so there is there are similarities that both Careteam and SHIIP share, and there are both unique capabilities. And together, we think that there is a strong opportunity to support your needs. So from an integration perspective, the opportunity is to integrate the shared care plans that both tools have, and to leverage the data, the power of the data that comes from SHIIP across the region, identify populations, and then be able to be patient-centered and bring those care plans into the hands of the patients and families that you're serving. Simone, I'm going to pause there and see if you want to add anything there.
No, I think that's great, Dean. Thank you very much for that.
So with that, Jamie, we could bring it back here. We could open it up to questions.
Yeah, if you want to stop sharing, I think it's always easier to have a bit of a conversation when we can see each other. So I think we did want to bring all these various players together so that we could have an opportunity to ask questions, learn more with the program or platform lead. So maybe we'll just open it up to questions or comments or reactions.
Jim, a quick question. This is Brad. Are there any integrations with pre-hospital EMRs, whether that's 911 side or community paramedicine? I imagine that's where you might get first line notification of acute issues or transports. Yeah, just curious about that. So TELUS EMR or TELUS pre-hos, ESO, those are the common ones.
Hopefully my internet's better and I can speak to that. Yes, we have on the Careteam side, we have what is called a Smart on Fire integration. So you can have a little widget within your EMR. So when you identify a patient with needs or something's changing, you can just launch that and it'll share key pieces of information from the EMR into there, and you can launch a new care plan or you can update a care plan from within the EMR. That's the smoothest and easiest way to do it. Simone, would you like to add from SHIIP?
Sure, and thank you for the question, Brad. Ideally, from a SHIIP perspective, we would want to integrate directly. So as the events are occurring in the pre-hosp environment, we would then, ideally, we would want to receive that data. So we currently don't have that at this particular juncture, but that has been earmarked as a potential roadmap item for SHIIP. So we're happy to have a conversation of what those integrations could look like.
Thanks, Brad. Did you have any other questions?
I just wanted to highlight, I did recognize our SHIIP use cases were presented in the meeting invite. So we do have a community paramedicine use case active in the Hastings Prince Edward County region. So they've been using SHIIP for quite some time. And we do have some interest in other regions as well. So with the increased interest from that particular sector, we'd be very keen to explore integrations. Thank you.
All right, Jonathan.
Thanks everyone for the presentation. I'd just be interested to know a little bit more about the notifications that you mentioned early on. So what format does that take? Who can trigger notifications, and who does it go to? And is there potential for it to drift over to sort of action planning and assigning tasks? So yeah, a little bit more information on the notification aspects would be helpful.
Thank you, Jonathan, for that question. So notifications are configured at the user level, and the users can configure the notifications to be presented in their inbox, or notifications can be completely contained within the SHIIP environment. So it doesn't hit an inbox. Recognizing managing email inboxes can be a bit a lot for those that are getting many emails. In terms of action planning and follow-up, so once the user accesses the notification link, that will take them right into the SHIIP application and right to the notification, where they can then hyperlink right into the patient profile, so they can see the encounter that triggered the notification. And if, for example, a care plan was active and attached to that patient record, the user could then make any updates in the care plan as needed. Right now, we don't have anything in the system right now that would, I guess, would support like a true action planning, but we could explore potentially the care plan functionality for that.
I think I was more thinking about who gets, is it a blanket system? So is everybody who's identified as part of the care team, if somebody initiates a change of documentation and wants to notify everyone, does everybody in the care team get a notification of what's happened?
That would be, so it is all configured based upon the user preferences. So the user would need to enable that notification to go to them. Otherwise, it needs to be enabled at the user level. So we don't send blanket notifications to care teams, but we would be happy to explore that functionality. So if that was clearly identified in the area of a care plan, we could think about group notifications.
And do you have any sort of, what's your feedback been on that? I guess I'm coming from the perspective of a concern about over notification rather than the ability to receive more notifications. That's where I'm coming from with this question. Particularly if the notification gives an implication, doctor notified, therefore it's off my hands and over to you.
Yes, indeed. And I would agree that notification alert fatigue is certainly something to manage. So we do have options in the system so that users can schedule when they would like to receive those notifications. So it could be 2 times a day, once a day, these type of things. And oh, jump-ins, I lost my thought on notifications. It can.
It sounds like what you're saying, the recipient can customize what they want to receive.
Yes, okay. Essentially, yes.
So maybe we'll just give a care team. Did you want to also respond around the notifications?
Sure, it's very much the same in care team. It's based on role. So depending on what your role is on the care plan defines initially what kind of notifications you'll receive. And then in addition to that, like you said just a moment ago, Jonathan, you can then as an individual user say which notifications you want to receive, how and when. This is also why we're adding the Health Report Manager integration, which I mentioned earlier in the presentation, through Ontario MD, because that way the problem with notifications that come by email or text is they cannot contain any personal health information, and they can inundate your cell phone and your email and so on. Whereas by providing it through a health report manager, it can come directly into your EMR, and it can contain much more useful content because you can see what the change has been. And it was based off one of the pieces of feedback from the health links, that they would receive the coordinated care plan by fax, but it was very hard to tell what changed. And so through the health report manager updates, we're able to very clearly distinguish what has changed and what the action is.
Anything else on notifications that people might have in terms of questions or responses?
My question is in regards to notifications and responses. Is there the ability for both the platforms to have an out-of-office alert set up by the user so that somebody is aware? Just explain more about that.
We don't have out of office alerts on our functionality, so that would be based on the user. From the SHIIP perspective, the user would need to configure when they would like to receive those notifications. If there's a need to do something like a vacation coverage. So we do have functionality within the SHIIP application where the subgrouping of patients that someone might be monitoring within the SHIIP application can be shared with another colleague within the same organization. And once that happens, their colleague can then activate notifications on that patient grouping list that one user might be managing and coordinating. But right now we don't have anything in terms of out of office, but we do have some limited sharing, patient list sharing mechanisms to cover things like vacation time or extended time off.
And with Careteam, in the messaging feature, there is out of hours notification. So if the person set themselves as out, the person sending the message would know that before they even send the message and would receive a notification. The other part, similar to what Simone said, but I mentioned the group actions feature. So if someone's going to be away for an extended period and someone else is going to be covering, they can use the group actions feature to identify all the patients that they want to transfer to another staff person and just literally transfer the primary responsibility to them. So now they're going to cover those patients for that period of time.
Anything else on notification? Okay, I did see Brian had your hand up. Do you want to ask your question, Brian?
Yeah, I come at this like from an analysis perspective. I imagine you'd agree though that the more data providers, the better, right? The more functionality, the more connections, the more potential. Can you give a bit of an overview like where we're at in Champlain in terms of providers on board or providers close to getting on board?
From a SHIIP perspective, right now we integrated with the Queensway Carleton Hospital, so we are engaged with other different groups within the Champlain region to activate data contributions. Ideally, from a SHIIP perspective, we do like to hang our hat on a project as opposed to knocking on the door and just looking for a data contribution. So right now we're just in conversations of what that could look like. But we are hoping the community support services integrations might be an option within the Champlain region, addictions and mental health, and of course the hospital sites.
And as of today, it's Queensway though?
Yes.
Okay, thanks.
Yes. So I think the approach ideally we would like to take is recognizing the hospital clusters and where they're sharing the same HIS. So recognizing that Queensway is on the CHAMP collaborative, we could have quick wins to integrating with the hospitals that are on that same collaborative. Technically, it's a quick win, but recognizing that there's still onboarding and privacy conversations that would need to occur to support that.
Thank you.
And I can say from the Careteam perspective, we're currently implemented with Briere and Care4, doing the at-home transition hospital to home. And we're now starting another project with Dr. Paula Bear in Ottawa around palliative care.
Does anyone else have other questions, comments, reactions that they would want to put forward at this time?
I have a question. I apologize. My raise hand function isn't working. In Renfrew County, we're working on a project to attempt to attach unattached patients to providers that are willing to care for them with respect to palliative care very specifically. And I did hear you mention about unattached patients when you were speaking. I just wondered if this would be a supportive way to try to roll that out, because that's the hard part is to have a way to house all of the information and connect people.
So the unattached program that we supported in Hastings, Prince Edward County did use our program management functionality to track and monitor patients that they identified as unattached. We also have the capability to identify unattached patients in the SHIIP application as well. So, and that is completely based on the data contributions that we receive, so that we have algorithms occurring in the background that can identify patients in that manner. But recognizing identification of unattached patients can look many different ways. So so I would say that there could be supporting functionality to support the unattached program in Renfrew.
Thank you.
And it's an area where I think the two platforms have slightly different focuses, but very complementary for unattached, because as Simone says, SHIIP can help identify patients based on the data that's coming from the different health system organizations. And then one area that we've worked in Careteam with unattached patients is we have a feature that we call self-sign-up, that if a person can self-identify and sign up for the platform, it can be done through a website with a link. It can be done with QR codes on brochures, on posters, etc. And they can self-sign up for the platform and be supported through the platform itself with electronic information. But then that also serves as self-identification that then clinical teams can then start to engage with them.
Thanks. We still have time. We did book, I think, 90 minutes for this meeting just so that we could have discussion. So if anything's kind of brewing in the back of your head, I think now is a great time to ask those questions. Sarah, I feel like maybe you have a question. I don't know.
I was wondering if there were, do you know, the leading projects, so the leading home care projects, because of course my mind is always on home care. Are SHIIP and or care teams involved in any of the leading projects?
I believe
both are. Simone, why don't you go first?
Sure, no problem. We had some preliminary conversations with the leading project groups, but at this time we're not supporting any of the leading project work.
And Careteam is involved in both the Mississauga OHT palliative project as well as the Nipissing wellness OHT project, which is more focused on community care. And we do have engagement with at least 3 others who want to move forward, but they're still sort of on hold waiting for the provincial approvals around use of the digital tools.
Thanks. Did you want any other questions, Sarah, or should I move to Jonathan?
I'm good.
Okay, Jonathan?
Similar vein, really, just but in terms of primary care, meaning sort of what sort of involvement with primary care providers, family health teams. I guess I'm intrigued to sort of like I still don't feel like I fully understand the operability of either platform from a family doc in a clinic working as part of a family health team, seeing how this can help improve sort of everybody's experience, both patient and provider, and in terms of like pulling together allied health professionals in the community and other people involved in a patient's care. So if you have anything you could share about how it's worked with family doctors and primary care providers, that would be helpful.
There are a
Sure,
couple. Oh, go ahead.
No, you go ahead, Simone.
There are a couple use cases in the document that's within the meeting invite. So first and foremost, our support within the primary care sector was very early days, which was the use of the coordinated care plan. So that's where at the time, home and community care, now Ontario Health at Home, as well as a primary care family health team and a hospital site collaborated on the discharge planning, and they would activate a coordinated care plan. So that was a very prominent use. We also have family health teams activating notifications. So they do find that feature, especially for patients that they might be monitoring a little more closely. They found that feature to be more handy than some of the things that were available within their own EMR. And the other use case is looking at patient populations and then extracting some of the information on those populations based on readmission stats. We did also recently support a COPD project, and that's where we merged primary care information with SHIIP information to support a quality improvement initiative. So that was with the Queen's Family Health Team, and they did a big analysis and then optimized some of their COPD initiative that they had within that family health team as well.
Thanks, Simone. Care team, do you want to give some examples on primary care work?
Yeah, I would say that our experience has been that it really depends on the use case and the nature of the family health team or the primary care provider. In certain use cases, as I mentioned earlier, the family doctor is going to be playing a very much more active care coordination type of role, in which case they may be an active user of the platform. To be monitoring their patient panel, engaging with the patient and family, engaging with other clinicians. In other cases, it has to be flexible, and that's why I mentioned the Ontario Hospital Report Manager, for example, where a physician isn't going to be as involved, but simply just needs to receive the notifications of what else is happening in the system for that person. So they can be making better clinical decisions, knowing what's happening, but B, they're not having to spend so much time following up on things because the inevitable telephone tag and faxes and so on that go along with the system currently. So if you can see a snapshot of what's happening for that person across the system, it does typically save you a lot of time.
Jonathan, do you have any other follow-up questions, or does that help sort of solidify from that primary care perspective?
Yeah, that's fine for now. Thanks.
Anyone else? We've heard from home care, primary care, hospitals. Any other questions, comments?
Sure, it's Lisa. I'll just jump in. But I was thinking, similar to Brad, it would just be a little bit curious about the integration with Epic. So knowing that most of our Renfrew County hospitals are using the Epic electronic medical record, and we're going that way as well. So just has there been like talk about how that integrates in? Because I'm thinking, I don't know a lot about it yet, but I'm hearing there are pathways built into our Epic platform. There's going to be, discharge communication. So does it integrate into Careteam and SHIIP somehow, or would it be a separate app outside of, that we'd have to go into, and how would it connect?
Sure, I can cover the sort of the clinical flow, and Simone can speak perhaps more to the data aggregation part. We have integrated with Epic as well as Cerner and Meditech, and the hospital EMRs are providing more functionality around like a discharge communication and so on, but they are still siloed and they are still quite limited. It doesn't, yes, it may provide a snapshot of the information at the time the person is discharged, but it doesn't provide any of the tools and functionality to then be able to support the person as they transition through. And for example, that was what I was mentioning, our project with Briere, with the at-home initiative, because where we then pick up at the point of discharge and support the person as they transition into home care. They know what they need to do. They're able to engage the person's family. They're able to engage other home and community support services with a shared care plan across the community. That's the key difference. The integration with Epic comes in a couple of different forms. One is when a patient is admitted to a clinical program or discharged from the hospital, they can send what you may be familiar with the term an HL7 electronic message to us to notify us that the person's been admitted or discharged, and that can trigger the creation of a care plan for that person automatically. So you then have a care plan in Careteam. We can also send information back to Epic, so there's a snapshot of what's happening in the community for that person. Simone?
From a SHIIP perspective, our integrations is based on the HL7 messaging as well. So we have integrated with Meditech. We'll be activating integrations with Cerner later this calendar year. And we are exploring an Epic integration in the Central East. So we do have sight and some experience with working with those different hospital systems. Very similar to the Careteam functionality, that when data is received, things can be notified, certain functionalities can be activated to support the patient flow that's occurring within and across the different sectors.
Right, so we're really supporting that transition piece for sure. Natalie?
Thanks, Jema. Jeremy, you mentioned that Careteams was involved with the Mississauga OHT in a palliative care project. I'm just curious, can you share if Chris, our EMR, is integrated within that project?
I can, and the answer is not yet. It was supposed to be, but then there were delays in the approvals. So they have decided to go live without it currently, but they very, very much want to have that in place.
Okay, I was really hoping for a yes. So okay.
Yes.
Great.
We have the they even gave us the specification. We've done the work on our end. We can do it, but we just have to wait for the approvals.
But you're getting close. Okay, that's good. Thank you.
Yeah. I mean, what I'm hearing is that as the responsibility transitions to the OHTs, the individual OHTs are going to now start to make those decisions to move forward.
Got it. Okay, thank you.
Great. Brad?
I'll just say really quickly, I appreciate the work on this. I think Jonathan's comment about, or Dr. Fitzsimon's comment about how does this work for the GP, like I appreciate that. In my perspective, like the further you get away from a GP's office or a FIT, the more disparate this information becomes and the more inefficient our work becomes, because we just don't know what's happening, right? We're in these silos. And so more statement than anything, like really appreciate this. Like these solutions are a lot of the things that we talk about in our own CP home care world. Like, I don't know what Bayshore is doing, who doesn't know what home and community care is doing, who doesn't know what the FIT is doing. So without a lot of effort in cases. So thank you. I think I speak for a lot of folks here that appreciate sort of a more streamlined solution to make all of our job easier and ultimately make the care that we provide safer for our patients. So thanks again, just a statement.
Thanks, Brad.
Well said, Brad. And you said outside of the medical sphere, I would agree on the primary care side, but example from our palliative care work in Mississauga does involve the physician side. I always remember that from one of our co-design sessions, the palliative care specialist physician from the hospital was saying that she has to fax off the referrals to home and community care. She doesn't know whether the fax was received. She doesn't know what the outcome was of that referral. Did it result in the services that she asked for, or some slightly different services, or no services? And then the patient comes back 3 weeks later and asks about the referral that happened, and she literally doesn't know. She has to pick up a phone and phone home and community care to try and find out, and so on. And then it continues on through the process and eventually gets assigned to a service provider in the organization, like Baycrest or Bayshore or St. Elizabeth or something. And they find they didn't receive the information that was from the referral from the specialist back at the beginning of the process in the hospital. So the bottom line was there were so many missed steps along the way that could have smoothed out the process, and that's ultimately what we're trying to solve.
Yeah, you're absolutely right. I just interacted with a client and I happened across a faxed report that I sent to his GP that he had hand scrawled a response to it and faxed it back to us and had gotten attached to the patient's documents. I never was notified. I never knew it happened. It's 3 months later, and I'm just today reading the response from the physician. It was nothing acute that needed to be actioned. Otherwise, I would have followed up. But like, yeah, this is what the world we live in is wild, and there are solutions. So thank you.
There are indeed.
We've had some great preliminary successes as well with our palliative care planning activities here in Southeast, and the clinician that we're working with had indicated just having the capability to share the care plan with others that are involved was astronomical for them. So they didn't have to repeat it. They didn't have to email it. They could share that information immediately, and they received feedback from the recipients to say that it was just the perfect amount of information for them, so they could continue on and move on with their care planning processes.
Thank you. Any more questions before we sort of close out? Now's the time. More statements. Thanks, Brad, for that. Okay, I do want to thank everyone, both the presenters and everyone that attended on behalf of your own teams for coming. We have recorded this, so I'll make this available. I'll probably put it on the OHT member site, but I can also send it out so you can send it to your colleagues, because we do know that there was people that weren't able to attend. I think for our next steps, I would encourage, as an OHT, we'll bring this back to the digital health. Jonathan is the co-chair of the digital health group for further conversation. We have our aging at home leads here as well, and some of the other partners. So we'll look from a variety of different perspectives of how and what makes sense for our OHT. And then perhaps what we can do is anyone interested can follow up with me, and then we can follow up with Careteam and SHIIP going forward to see if we can make those connections. Or if you really want, you can connect directly with Jeremy, Simone, and Dean. But the OHT would like to know what you guys are doing. So thank you very much for your time. We look forward to having further conversations around this and seeing what's possible for within our area. Any other closing thoughts, or can we say goodbye? Great.
Thank you, Jenna.
All right.
Thanks everyone.
Thank you.
Bye.
Bye.
Great day. Thanks.